Hello, good evening. I hope you can see and hear me. I've been trying to do a live presentation, and obviously, pre-arranging it doesn't seem to work very well because whenever I have tried, we don't see much response, and I've just figured out an option to do it, and I hope it works this time. If you can see or hear me, just put a thumbs up in the chat window, and let me see if so it looks like you can see me, and I'll start by first of all thanking all of you for supporting the growth of my channel. And obviously the purpose of this channel is more to share education, and knowledge is power. At the same time, it gives me an opportunity to keep in touch with many of you. Some of you are my patients from previously. I'm not doing many clinics these days. I'm focusing more on the inpatient work, the neonatal intensive care, and I do miss clinic interaction with many of you. I often remember the fond memories, so obviously I'm looking at getting back in touch with the clinics. I've started just the neurodevelopmental follow-up here, and due to the pattern of the work, due to the NICU being very busy, the clinic work is not taking priority. So for the patients among you who may watch this video either live or later on, thank you, and thank you for sharing, and thank you for commenting to share your affection. I still have fond memories of my interaction with all of you. I miss seeing you guys, and hopefully it will start again. For the medics, the nurses, and the doctors among you, I really enjoy teaching, and it's very important that we stick to basics. Going to the advanced stuff without understanding the basics is difficult, and at the same time focusing too much on the advanced stuff without focusing on the basics may mean that you end up doing more than you need to. So one thing to start the session today is just a tip on how you can utilize the time effectively. Obviously, being fit is very important. Exercise is a very important tool, and we need to have some form of activity built into our routine. So for example, I tend to run or walk almost every day, and keeping a count of the steps you do is one way to motivate yourself. Challenging yourself, pushing yourself with someone else is another way. And obviously our days are so crowded that if you don't manage your time effectively, you won't find time to exercise or to learn. So I combine learning with exercise, and most of the time when I'm walking or running, I have the YouTube videos either from my channel or other educational channels running in the background. Most of the time the visual stimulus is not an essential part of watching a lecture. The auditory stimulus is adequate for you to gain the information. So it's you can always pause in between, review, or come back and review the slides you want to share. Of course, if it's a very visually based presentation like a radiology presentation or something, you cannot really do it unless you're sitting and watching. Similarly, if it is too statistics based, you need to focus more on the numbers. And but if it's mostly the sessions I do for parents, for example, or the simple teaching sessions, audio is enough. And actually when you're exercising, your focus levels are really high. So if you are doing it in a peaceful place where there is not much background noise, it's a good option to combine. Of course, the data on your mobile phone will be consumed, so one option around that is to download, plan what you want to watch during that time, download it, watch it, and if your phone doesn't have memory, delete it. So podcasts are an interesting option as well, which I thought of, but it takes more effort. and I won't have time to do both the YouTube channel and the podcast, so balancing it. I'm trying to answer your queries on the YouTube channel as and when they come, and thank you for your patience if there is a delay. At the same time, I don't have time to reply to individual messages or emails which are directed to me. So if it is patient related, I would request you to post it as a comment on the channel, so it saves time. So I was thinking I'll discuss some aspects of recent updates in neonatal jaundice, and if you have any questions, you're welcome to add on to that. So just to start today, I hope you can see the slide now. So the first step in understanding jaundice is to have an overview of the bilirubin metabolism. So as we know, bilirubin is produced from catabolism of the red blood cells in the reticuloendothelial system, and when the heme component is broken down, 75% of the heme comes from breaking down of the effete red blood cells. The heme oxygenase converts the heme to biliverdin, and there is also a portion of bilirubin which comes from ineffective erythropoiesis in the bone marrow, and there is also heme in the tissues in different enzymes and in the muscles as well in myoglobin. So they contribute about 25% of the heme load. So the biliverdin gets acted on by biliverdin reductase to form bilirubin. So bilirubin gets bound to serum albumin and it circulates. It reaches the liver where it is taken up by the liver ligandin, and in the smooth endoplasmic reticulum there is conjugation happening in the form of glucuronosyl transferase enzyme acting, and that is called the conjugated bilirubin. The unconjugated bilirubin is mostly bound to the albumin. However, if your serum albumin binding capacity is overtaken either by a very rapid production of bilirubin or by the albumin being low, you may have more free bilirubin, which is one of the important factors that play a role in brain damage or brain injury. So once the conjugation happens, the bilirubin glucuronide, mono or diglucuronide, is excreted into the gut. Part of it gets absorbed back by the intrahepatic circulation and may come out in the urine as urobilin, and the fecal bilirubin urobilinogen is minimal. And then you have glucuronidase enzyme which may act in the gut contents. So if there is stasis of the bilirubin passage through the intestines, for example in meconium ileus, or in a baby with hypothyroidism where the meconium is not passed adequately, you may have increased reabsorption. And sometimes we will discuss later, the breast milk contains glucuronidase enzyme, which leads to persistent unconjugation and reabsorption of the bilirubin back into the bloodstream. So this leads to prolonged jaundice in a breastfeeding baby. So bilirubin is physiologic to an extent, and it becomes a severe hyperbilirubinemia when the levels exceed a normal range. So it's interesting to note that a level of more than 17 milligrams per deciliter or 291 micromoles is seen in 1 in 10 babies. So it's a fairly high number, and this is usually the treatment cutoff, though the low risk babies don't get started at this level. In clinic practice, most clinicians and the AAP guideline also suggest that where in concern you can start 20 to 50 micromoles below the threshold mentioned on the AAP charts. So that would come in this range. When I was training, 20 milligrams per deciliter was the cutoff for exchange transfusion. We didn't differentiate the well babies from the babies who might be sick and hemolyzing. So this more than 20 milligrams per deciliter cutoff is very important, 342 micromoles per liter, and it indicates severe jaundice. The frequency drops from 1 in 10 for more than 17 to 1 in 70, and many of these are pathologic. So that's the reason most of phototherapy charts advocate phototherapy at this stage. Of course, it's not common to see babies with more than 25 milligrams, which goes to very high levels, and we start getting features of brain injury beyond that level. Of course, the proportion of babies who get brain injury at this level is not high, but you do run a risk, especially in the growth restricted babies or in the premature babies. So the number that where it reaches more than 25 milligrams is 1 in 700. The really hazardous level is more than 30 milligrams per deciliter or 513 micromoles. Most of the babies would need exchange transfusion when it touches this level, and if they have features of brain injury, you would need to rush into exchange. This is luckily very rare. It's 1 in 10,000 live births. So this is the group of babies where you get kernicterus in the developed countries when they were discharging early on, and that is why most of the current tools that we use, the screening for bilirubin at discharge, the repeated checks and so on came in. So we want to avoid babies going to this 25 and 30 milligrams. So you can see what a big difference it is, 1 in 700 to 1 in 10,000. So more than 30 is definitely very, very abnormal. We should not let it go to 25 because some babies may start getting brain injury at this level. And more than 20 is usually the threshold for treatment in a well baby with non-hemolytic jaundice. But very often we start at more than 17 because we are sometimes not clear about whether it's hemolytic or non-hemolytic, and it's safer to treat than be worried about it as well. There is also a very important factor, which is the impact of gestational age on the jaundice risk. So even though we say more than 37 weeks is full term, you can see that the 95th centile for the jaundice is really high at this stage. It starts dropping. So 36 and 37 week babies are at quite a high risk of significant jaundice, of bilirubin reaching. So this is the percentile. So the 95th percentile and 75th and so on. So you can see clearly that the rate drops very significantly beyond 38 to 39 weeks, and in 40 weeks and above it drops quite to reasonably low level. So less than 10% of the babies would have bilirubin crossing this level physiologically. So it's very important that the obstetrician tries not to deliver the babies before 38 to 39 weeks, not only for the respiratory problems but also for the bilirubin risk. Just a quick overview of how phototherapy works. So unconjugated bilirubin absorbs the light most strongly in the blue region of the spectrum, and the wavelength of light in this range is 460 nanometers. As you might remember, phototherapy was discovered by a serendipitous observation by one of the nurses in UK. She observed that the babies who were nursed near the window had lower levels of jaundice, and she used to start keeping them out in the sun for a period of time. And the white light phototherapy was the one that was introduced in the beginning, and then they discovered the efficacy was more with blue light, and the 460 nanometer was picked up. So there is direct relationship between efficacy of phototherapy and the irradiance used. There are three photochemical reactions: photooxidation, which plays a minor role. There is a disruption of the bilirubin molecule, and it forms colorless polar fragments. These are easily excreted in the urine. And configurational isomerization. This is a structural change where it becomes water soluble, and this is the bulk. And structural isomerization, which is a major role, and the structural formation of lumirubin is irreversible. It contributes 6 to 10%, while the rest of it is a reversible form. It's very interesting that the action of phototherapy starts within a few minutes or even about 1 hour. There is a significant conversion of this configurational isomerization. It's a very quick process. So phototherapy starts acting immediately, and even though this isomer may still be measurable in the serum, when you do the serum bilirubin, the actual level comes down. The effect on the brain, the efficacy to crossing the blood-brain barrier drops. So the bilirubin toxicity drops soon after you start the phototherapy, which is intensive. So the irradiance depends on the radiance of the light, the distance from the unit, and the other important factor is the surface area. So anything that increases the surface area, like increasing the number of lamps, keeping a blanket underneath, having a lamp underneath the baby with glass shield, perspex shield, having a drum phototherapy unit, all these are very effective ways. And it's very important the unit has a policy to regularly monitor the effectiveness and maintain adequate hydration. So these three important topics have been discussed, and I will be discussing some of the recent updates on jaundice management in the coming couple of days. So there are a couple of questions. Let me see. Sudha, what is the reason for back bouncing of jaundice in newborns? So do you mean rebound increase in jaundice? So obviously if you think the jaundice is physiologic jaundice, we don't really need to wait for the rebound to happen. You would have an idea of whether it is physiologic jaundice or pathologic jaundice depending on how quickly the bilirubin drops. So basically, as you know, the balance of jaundice is where the bilirubin production and the bilirubin excretion is balanced. And if the baby has a hemolytic cause or any other reason why the bilirubin is rising rapidly, the rate of drop with the phototherapy will be relatively lower, or you may not see a significant drop despite giving effective phototherapy. So if your bilirubin starts dropping quickly, it's very likely that it is responding well and the rate of production is not very high. The same parameter can be used in babies who have received phototherapy for a couple of days, and then you see that the similar irradiance of phototherapy or similar exposure to phototherapy is dropping the bilirubin more. It means the liver is starting to mature, the production rate is dropping, and both may happen in parallel or at different time frames. However, if you have pathologic jaundice, it's always better to observe the baby for a few hours after you stop phototherapy, recheck before you send home, mainly to avoid the hassle of readmitting. In any case, you have to review the baby within 1 day or so of stopping the phototherapy, even if you're discharged without waiting for the rebound. And if you mean the rebound happening after the exchange transfusion, it's because the bilirubin redistributes after the exchange. So it's distributed in the various tissues. You are removing mainly the bilirubin which is bound in the albumin in the plasma. However, the ones that is in the tissue comes back into the circulation. And the same way the isomers that are produced by phototherapy can temporarily change back to the active form as well. So that is another reason. And there is another question from Pari. So what is the outcome of mild pathological jaundice in the phototherapy range on day 5 if we don't treat it with phototherapy? So basically, the phototherapy guidelines have been produced keeping in mind the risk, and obviously you are already at day 4 or 5, and in ABO incompatibility it may or may not be the ABO incompatibility that is contributing to this jaundice. So usually the hemolytic jaundice due to ABO would present in the first 2 to 3 days at least. So if it is going to day 5 for a significant jaundice, it's more likely the exaggerated physiologic jaundice. Whether the blood group difference is playing a role, we don't know, because ABO incompatibility is one of the more difficult diagnoses, because you may have a direct Coombs test positive, at the same time baby may not hemolyze, baby may not have significant jaundice, and you may not have a Coombs test positive, at the same time the baby presents acutely with signs of hemolysis, a drop in hemoglobin and so on. So there are various factors, and of course the OB setting is more severe than the OA setting in many situations, and sometimes you have the rarer blood group differences overlapping on that as well. So you can closely monitor these babies if they are approaching the phototherapy range. You don't need to assume it's hemolysis. You can always do a hemoglobin to check, and of course I will be coming on to the importance of carbon monoxide as a measure of as a tool to see if there is hemolysis. Of course, most of us do not have access to that test, but it's one of the more recent advances of bilirubin treatment. So you can closely monitor the child. If you have a transcutaneous bilirubin and you have the serum bilirubin at the first time, you can use that as a trend. You don't need to necessarily do a serum bilirubin every time. And if the trend in that baby is reliable, you monitor. If it's showing a significant rise or it is not dropping well enough, I would suggest doing a serum bilirubin after 2-3 days when you continue monitoring. The impact of a borderline bilirubin on the brain is unknown. Most probably, unless the baby is premature, or baby has other risk factors like sepsis or asphyxia or a low albumin, a level of 22, 23 is not really going to harm the baby, but it is more a threshold where you don't want to exceed that, so you want to treat them before that. However, if it crosses 25, you would be worried. So the group that you're talking about is mainly the babies who are in the 17 to 20 milligram range, where it is approaching phototherapy range, but baby is already day 5, maybe the breastfeeding has set in, you're starting to gain weight, and you may not want to admit the baby and stress the parents. The cost also comes into play in this situation, so you may decide to wait in these cases as well. So I will close this session with this, and we will resume another day. I think I figured out how this works, so hopefully we can do it more often. Thank you, everyone.